over here.
Good morning, everyone. He did butcher the garage, but he also butchered my first name. It's Pranam. So that's okay. I've been called worse. But good morning, everyone, and thank you so much for your time this morning. Thanks to HPN for allowing us to sponsor this, hosting us today. It's an absolute pleasure to be in San Diego with Dr. Howard, CMI of Adventist, who I've gotten to know over the last 6 months or so, an absolute brilliant mind. And in my top 5 CMIOs in the world, he's at number 6. So he's getting there. So thank you. And my colleague Stacy Fox is here as well. On behalf of all of us, thank you so much. Today, what we thought we'll do, unless you've been living in a cave, you probably have heard of CMS's RFI for improving interoperability and driving more value-based care in the country. So we thought we'll dig into that for about 20 minutes, look at it from different perspectives, and hopefully this will be an engaging session. So to kick this off, just to get the introductions out of the way, I'm Pranam Ben, founder and CEO of The Garage. We are a population health management platform company that is focused on changing healthcare for good, one community at a time, one provider at a time, one patient at a time. And yes, we do fix cars, but you never know how the quality of the work, but we do healthcare platforms really well. We've been around for 13 years. I still remember the day I started the company, which was April 1, 2012, was the first day of where MSSP ACOs were formed in the country. So we've had a very harmonious journey with value-based care over the last 13 plus years. Today we operate at scale. We have a presence in about 36 states, more than 15 million lives managed on the platform, almost 26,000 providers integrated on the platform, more than 3 petabytes of data on our HIPAA-compliant, high-trust certified infrastructure. And most importantly, where we truly measure what matters to us, the impact that we have in the communities that we partner in. We have more than $1 billion saved in the last 7 years by our ACO partners. So it's been an absolutely humbling, fascinating journey, and I believe the timing is now for all of us to come together, be bold, and change the status quo in healthcare. So that's basically our commitment. That's the work that we have done, especially working with partners like Adventist. So very, very thankful for this opportunity and an amazing journey that the crew and I have had. With that, I'm going to request Dr. Howard to introduce himself and Adventist.
Sure. So I am the CMIO for Adventist Health. I've been there for about 1.5 years. I've been in informatics since the 90s, implementing systems, de-implementing systems, optimizing. I've also been very involved with training of informatics. I've been the chair of the Association of Medical Directors of Information Systems, which is a really old term because that organization was created in the mid-90s. And I've been the chairman there for 6 years and was the vice chair for many years before that. And given us through the organization called AMDIS, we participate in comments for public comments for bills that are being proposed. We work with HIMSS, we've worked with CHIME in the past, we've worked with AMIA. So a lot of what we're going to talk today comes from those kind of discussions. Adventist is a 28 hospital system throughout California, 3 hospitals in Oregon and 1 hospital in Hawaii. I'm not sure why, but Kaiser, Sutter, and Adventist all have a predominance in California and a presence in Hawaii. I think that's because someone on the board really wanted to make a nice trip occasionally. So it just seems to be a theme of hospitals in California. But we're over 400 care centers. We're the largest rural healthcare provider in the state of California, and we're one of the largest rural healthcare providers in the country. I joined really to take them from the Cerner EHR they were on, move them onto the Epic platform, and while doing that, completely transform the organization. We were a very diverse organization of hospitals that came together through mergers and acquisitions, medical groups that joined us, and we have an incredibly non-standardized approach to delivering care and to our technology. And this project is designed to rationalize hundreds of applications out of our system, get everyone on a single platform, on standardized workflows, and really improve the quality of the care we deliver and the quality of the experience our clinicians have in delivering that care. And the garage has been one part of our value-based care journey. as we work through how to really provide the best care in that venue, as well as fee-for-service, Medicaid, and every other payer situation that we're involved with.
Thank you, Dr. Howard. Before we look into what a point of view or an architecture could look like to help realize the core tenets of the RFI into a realizable solution, the first thing that we want to think about is, what does it mean to be bold, right? What does it mean to be bold in healthcare? You know, it's to imagine what's possible, to reimagine the ordinary into extraordinary, to leap into the unknown, to take the first steps. You can rationalize with it in many different ways, and we've taken our own approach. But just to kind of like think about, you know, an inspiration, a reference, you know, I want to transport all of us back for the next 5 minutes to July 20th, 1969, when we set foot on the moon for the very first time. It was the first time that humans set foot on any celestial body. You had President Kennedy in 1961 set a mission, a vision for all of us to, you know, have a man go to the moon and come back before the end of the decade, and it was successfully achieved. Now, if you think about just that Apollo 11 mission from different perspectives, you know, if you think about the fact that the computing power in the lunar module that landed on moon is the same computing power that we have in a handheld calculator today. So to achieve that kind of a mission, that kind of a generational impact with that mission should be an inspiration for all of us. And even the event, if you think about how it brought people across the world, apparently there were 500 million people that tuned into the live event when it was beamed. And if I just think about what would it mean in today's world, that would be 1/3 of the world's population tuning into a single event. So it was such a great unifier across generations, across boundaries, to bring people together. 950,000 miles traversed, 47.5 pounds of soil and rock and other samples that were brought back, and it set the tone for every mission that happened after it. It continues to influence education, healthcare in many ways. So this has been a mission, is something that inspires us at the garage, and I kind of thought we'll look at it together to use that as an inspiration as we look at and understand what CMS is trying to achieve with this RFI. And if you just look at the core tenets of the RFI that CMS put out, and all of us participate, that's the other thing that I was absolutely pleasantly surprised is the amount of participation we saw from the community. I mean, we did our bit, we responded as well, but it was almost like the entire community was starved, was waiting for CMS to give an opportunity to present a point of view, to present an architecture and share ideas on how to change healthcare. These are the core tenets of the entire RFI as CMS defined, and I would love to hear from Dr. Howard on his thoughts, because at the end of the day, the work we do is to empower people like Dr. Howard to provide better care for their patients.
Yeah, I'm always a little skeptical of the government when it comes to working with us in healthcare, and I think that's well borne out by experience. But they're all, every time they reach out and ask about something like this, it's an opportunity, because some of the things will come to fruition. This was, I think, a 1,400-page bill that I did not read, but I did talk to people who did. But so many of the things, really changing our healthcare system to have a more digital experience, changing that, patient access and patient engagement. We have so many tools now that are available, and with the evolving artificial or augmented intelligence that is now available, combining those, I think, are opportunities for us to care for people that we've never seen before. So making sure that barriers are taken down, making sure that the barriers to interoperability continue to come down. We've made huge strides in the last decade or more, but it is still not easy for providers to get all the information they need about their patients. Value-based care is, I started my practice in 1990, and at that point I was told, within 10 years, value-based care was going to be the way care was going to be delivered across the United States. In 2025, I'm hearing that in about 10 years, it should be the way it's going to be delivered across the United States. We'll see if that comes to fruition, but there certainly are huge opportunities, and understanding how the technology can really support that now, and taking those barriers down to data sharing, to data use, are going to be huge if we can bring this off. Electronic reporting of quality measures has been something that's been available since mid-meaningful use. They've been more analytic, more abstracted measures in many cases. As we move to more digital measures, this bill also addresses the ability for us to use real extracted measures, taking the burden down of identifying opportunities for us, improving the quality of care, and actually reporting in a more standardized way, so we can really learn from each other and share with our patients, is an opportunity that is buried in those 1,400 pages. So there's a lot to unpack here, and we're going to have to see what the government finally comes up with, but lots of opportunities for us.
Thank you, Dr. Howard, and I hope it leads to many programs that anchor us on the realities of each of these tenets and help us participate together to drive real change in the areas that matter. So just to kind of piggybacking on what Dr. Howard said, we've been working on these different dimensions for years now, but we thought, okay, let's kind of share what is a potential system architecture that could help drive the realization of those core tenets. And this is an architecture, this is something that has guided us in everything that we've done over the last 13 years. This is not a response to the RFI. The RFI was a validation of the work that we've been doing, but this is what we call the DFDF architecture, or the digital first, data first architecture. And I'm going to quickly walk us through this from bottom up. Everything starts with data first in everything. For us, in value-based care especially, data is king. So we've created a normalized data warehouse at scale that gets data from all sources regardless of size, location, specialty. In fact, I have this saying, if you store your data in the dishwasher, we'll go get it. We are that obsessed about getting data because without that, there is no value on the front end in the platform. And the data then gets normalized with the platform as the command center aggregating workflows, driving that intelligence that then gets served up to this very interesting layer that we call tiny tasty morsels, which is in all the complexity of the data, in all the exhaust of the data, how do you get the stakeholders to listen to the signals and eliminate the noise? So creating that rich, simple, meaningful tool set that's decentralized and available at the point of care became the kind of our secret ammo, if you will, to drive the effectiveness of the platform 300% over the last 5 years. So that's been a layer that we've invested heavily, and which is where AI gives us a great opportunity to bring in real change, real experiences. And at the top, we've unified the access for all stakeholders regardless of role. That's been very important for us to understand that you can create a digital front door at the point of access, but what is also equally important is to understand the in-person encounters, the in-person experiences that patients have, because at the end of the day, healthcare was, is, and will always be human-centric. So we're digital first, data first, platform-based, AI-powered, but human-centric. And in that core tenets, what we've done is to look at each of these layers and invest in AI-powered experiences. We have a data agent called Genome that is normalizing the data. We have a platform agent called Kiosk that is driving decision intelligence. And we have a suite of agents called Blaze agents that are driving that decentralized, rich experiences. So this is architecture that has guided us. And today, this entire architecture is being relitigated by AI in real time. And that is exciting and challenging for us. So this is our investment, this is our enablement. And if you see this, today the platform has a version, it has a form, tomorrow it's going to be transformed, but this architecture will continue to guide the work that we do with organizations like Adventist in all the opportunities that they have. And just to spotlight the work that we have done with Adventist, which is this has been we started partnering with Adventist last summer, so it's been less than a year. And if you look at, the before we came into the picture, Adventist was participating in accountable care contracts and with a group of independent affiliate practices and the core physician network. and very disjointed. The systems didn't talk to each other, which was the gravitational force to bring us into the equation. And since when we implemented our platform called Bridge in less than 3 months, and we've not only have aggregated the data into a unified experience, we've also gone and scraped the universe to get additional data assets, like Health Gorilla as an example, which is the nation's only dual designated QHIN and QHIO clinical aggregator network, having data for more than 230 million patients in the country. And we are a strategic partner to Health Gorilla. We went and got the entire clinical histories for all of Adventist patients, brought it into the data warehouse, ran multiple risk models, looked at enabling all kinds of insights at the point of care, driving actionable insights, and truly improving the cost of care. So this has been an amazing experience, and I believe we're just getting started in the world of Adventist, and we are doing very similar work with very similar case studies across the country with all the organizations that we have partnered with. Dr. Howard, if you want to throw this.
I'll underscore, we have dozens, if not hundreds, of different value-based care contracts. They all have different requirements, they all have different quality metrics they're following, they all have different incentives, upside, downside, and capitation. So trying to figure out how to take care of those patients in a coordinated way was incredibly difficult. In addition, many of those patients aren't seen by us. We're accountable for them from a reporting and a risk perspective, but they're seen by our community providers, the independent providers who use our hospitals or are our partners. So we needed the data that they had, and they don't use our EHR, and they need the data that we have. So by bringing it all together and serving it up, that layer to the patients, to the providers, to the clinical staff, and being able to talk about what HCCs have you or have you not documented this year? What care gaps have you closed? What kind of opportunities do we have on the expense side? Who's our high-risk people? Leveraging our population health, our care coordinators, as well as our frontline clinicians, giving them that data allows them to make much better decisions and do better interventions. You know, nobody wants to have someone called for a care gap they closed somewhere else recently. No one wants to be reached out to say, hey, go get this test when you've already been diagnosed with a disease that makes that test unnecessary. It's work for our side. It reduces the appearance of our reliability to our patients, and hey, do we know what we're doing? And provides a better experience for them because we're not bothering them with things that they don't need to deal with. So putting that data together really provides that power to reduce our efforts and provide the best care we can for them.
Thank you, Doctor. And one of the things that I should applaud Adventist, when we went through this project, Adventist was one of the few ACO organizations in the country that chose to report on CQMs when it was an option. So you didn't have to report CQMs this year, but they went bold with it. They were stubborn with it. We actually did so much work with their core EMR system and the affiliate EMR systems, but we also went to external sources. We brought in normalization engines, and it was an intense experience for both teams to be able to successfully report on CQMs and set the foundation for that exponential growth in quality scores and quality of care. So it has been an amazing experience, and I'm looking forward to what the next few months and years brings with Adventist. Just to kind of for us, this is our strategy to bring data and infrastructure, the platform as the command center, the AI agents driving tiny tasty morsels, and bringing people and process together to bring in real change in healthcare. Just again inspired by the Apollo 11 mission, where the sky is not the limit, it's just the beginning. That speaks to our relationship. It speaks to the opportunity that we all have. So the request and the message here is, let's all go do things that we are scared of and break things that are supposed to be bent, so we can then bring real change in healthcare. Thank you very much. I appreciate your time this morning. Thank you.